Welcome to Population Health Information Technology, Technologies for Successful Population Health Management. This session will take 30 minutes to view and is the second of 4 sessions in this series. This session will focus on the population level technologies and data analytic techniques which have proven successful for organizations who have been rewarded through their value-based care contracts. Our objectives in this second session are to describe the major steps involved when using population health management (PHM) applications, identify data sources that PHM needs for analytics, and recognize the importance of risk identification and stratifying and segmenting patient population data. Here is a list of many acronyms and terms we are using in this series. Please pause on this slide if you need to review any of these. Most of them were reviewed and defined in Session 1. Let's talk about population health management as our first topic in this session. What is population health management and why is it a key component of value-based care? In Session 1 of this series, we discussed that a shift to population health management enables healthcare providers to proactively improve outcomes for an entire group of people by delivering standardized, holistic services for every patient through the use of a variety of supportive technologies. Technologies that support population health management can help us collect, analyze, and stratify the broad sets of data to gain insights and translate these insights into action and interventions with patient groups and individual patients. Analytic tools can help us better understand the population as a whole and concurrently provide more detailed insights and information for providers to make better and more well-informed decisions for their individual care, and other technologies can help ensure seamless care coordination or improve patient engagement. As for the why of population health management, succeeding in value-based care means transforming the way care is delivered to improve the health of the population, shifting from a reactive to a proactive approach to supporting patients that improves quality and efficiency by supporting delivery of the right care at the right time in the right setting. When done effectively, all members of the care team will be called on to modify how they carry out their work, and the first step is using population health management to understand the bigger picture for all patients within a defined population. Another key component for those moving to value-based care is providing an annual wellness visit for every patient within the population of patients we serve. This type of encounter includes screenings and other preventive services aimed at keeping patients well in all aspects of their life, preventing unnecessary encounters and services, keeping our patients out of the hospital, leading to reduced costs. The reduction of costs leads to sharing of the savings that are realized in a value-based care model. The comprehensive documentation about a patient's current health status, medications, diagnosis, family, and social history not only inform the current decisions and steps to improve health and complete necessary preventive screening tasks, it also allows the clinician to analyze that individual as part of a population to inform system-level policy and program needs. We'll see this symbiotic data loop in an upcoming slide on data collection. When we look at population health management from an action perspective or putting it into practice, we focus on the steps needed to work with a patient population to improve their collective health one patient at a time. The bullet points listed here are some of the population health management activities identified by the National Association of Accountable Care Organizations that organizations engaged in value-based care may want to focus on: medication reconciliation at outpatient visits, medication therapy management in outpatient settings, chronic disease management programs for people with specific diagnosis, efforts to reduce preventable readmissions, and post-acute care integration. We'll talk more about specific technologies that support these activities in Session 3. When looking across the many population health management vendor solutions offered in the marketplace, most, if not all of these, have capabilities in common. The applications or vendors may refer to them with different labels, break them into different or more precise categories and subcategories, but we'll organize this session around these 3 steps here: collect, analyze, stratify, and segment, and utilize. Each vendor solution typically follows these activities by first pulling together a large and disparate set of data, preparing that data for analysis, then enabling the user to conduct analytics in a variety of ways and methods. Subsequently, they then take action based on how the data was stratified and segmented into population groupings with, for example, similar disease diagnoses, common health risk factors, or certain age groups, which can be utilized at the individual provider level to improve and maintain health. In the following sections, We'll break out each of these three categories to understand and explore the activities needed to conduct each step and talk about a few challenges involved in the work. Many vendors offer tools to support population health management, each with their own unique capabilities and ways to differentiate themselves from their competitors. From a functionality standpoint, vendors may differentiate themselves by offering different methods or tools to extract data from source systems, the ability for end users to segment and stratify the data with different analytic tools and views of the data, and how they package and present detailed analytics at the diagnosis, provider, practice, and various organizational and/or system levels. An interesting set of statistical insights from definitive healthcare data revealed that as of September 2019, nearly 50% of all hospitals reported utilizing some type of population health management tool. More than 75% of those used tools developed and embedded within EHR vendor products, such as Epic, Cerner, and Allscripts. However, 38 unique vendors were reported at the time of this survey, and that number has increased since the time of this recording. A couple of examples of what this might look like in practice. Aledade is an ACO management company that works with a variety of providers. This snapshot shows their very high-level approach to managing data to support population health. In broad strokes, their formula to help clients starts with collecting data from across the care continuum, starting with a large number of EHRs that they can extract data from, merging it into a single application, which is based on the Tableau analytics platform, a very common application for data analytics across many industries. They then take this comprehensive data set and transform it into actionable insights and produce such outputs as risk analysis, specialist utilization reports, recent hospital events, and preventive services information. Their final major step is to equip providers with this data to conduct conversations with their patients on their health and offer needed care coordination, and in doing so, reduce unnecessary visits to save time and money for the patient and for the healthcare system. This is another example of a vendor platform that can be used to manage population health. You'll see that their approach follows the similar three major step pattern with specific activities underpinning each step. Don't worry if you can't see some of the details in this infographic. We're concerned with the high-level information about these three key steps. The graphic here from Health EC, the class KLAS 2022 Population Health Management category winner, we'll talk about this organization more upcoming slides and touched on them in session 1, shows a different and slightly more detailed view of common steps needed to accomplish the major steps in population health management. This graphic displays the three main steps of acquiring data, e-connectors as a way of accessing needed data, normalizing the data, a way of standardizing it so data from various sources can be combined and used alongside each other in a population health management application, or any database application for that matter, and transforming it within a data warehouse and then conducting analytics and pushing out results for clinicians to use in their direct patient care workflows. The first of three major steps in population health management is collecting the data, which we'll look at now. The first of three major activities that occurs in population health management applications is collecting data from a wide set of sources. The left hand of the slide lists out many sources that you may consider pulling data from, including public health sources, disease or diagnosis registries, electronic health records, continuity of care documents extracted from EHRs, a variety of data enabled through health information exchange, payer claims data, labs, and behavioral health. In the middle, the three boxes represent a few of the methods of retrieving the data and transferring it to the population health management application: health information exchange, point-to-point interfaces, secure file transfer, and others. Data sets are received and processed through a series of steps based on the unique characteristics of each set of data, the frequency, standards, and so on, to cleanse, transform, and normalize or standardize the data into a usable format where it can be considered reliable, accurate, and useful for analysis and decision making. The circular arrows of the population level circle indicate the continuous cycle of data collection needed to have the most recent data for analysis. The smaller patient level circle and continuous process arrows communicate that as we interact and have encounters with our patients, we are documenting detail that can be used not only at the clinical level over time, but the data feeds the EHR, which is a source to gain insights into the population as a whole. Thus, the documentation that is done is aggregated along with other encounters, and we can learn about the health needs, gaps, etc. of our attributed population. Note that social determinants of health data can be pulled in from public sources that describe the environment our patients reside in, by zip code, for example, but that very specific social determinant data about a patient, their family circumstances and needs, can only be obtained through direct screener questions filled out by the patient or with assistance from staff or providers. Data that helps us to understand our patients, in other words, can come from both patient-specific and broad external sources and helps form a better and holistic picture of an individual's circumstances and needs, along with many other forms of data that we collect. We'll talk more about social determinants data in sessions 3 and 4. The ability to aggregate information and data sets from many sources is a must. A healthcare organization can provide one of the major data sets from its EHR, but as we saw in the prior slide, there are a growing set of external data sets that a population health management application requires to conduct the analysis and apply sophisticated algorithms to it. To mobilize and collect broader, more informative sets of data, we need the help of health information exchanges. HIEs are organizations that provide the service and movement of the data between systems and organizations. The field of HIE is a very dynamic one. HIE organizations and data standards groups are gaining consensus on reliable and consistent ways and processes to enable the effective and timely exchange of data. Exchange standards are necessary to serve many needs, only one of which is acquiring data for the technology managing populations. Not only is the ability to collect data a prerequisite for population health management, with HIE being enabled in this process, but when we start translating the population level data into actionable patient level data, HIE continues to be a conduit to build and maintain a longitudinal or holistic patient record. The back and forth nature of data inputs and outputs relies on the ability to bidirectionally exchange data. The Healthcare Information Management and Systems Society, HIMSS for short, also comments on the importance of HIE for ACO success, again an ACO just being one form of value-based care. They state on their website that, quote, "The opportunity is ripe for HIE organizations to assist ACOs with tracking down rich episodes of care and diagnostic data, developing patient profiles and assembling continuity of care records to assist ACOs. Beyond care coordination, HIEs will prove essential in ACOs addressing the other performance measurement domains as well. Through connectivity with personal health records managed by ACO patients, HIEs will provide communication between patient and ACO physicians so that the patient can receive timely care, schedule appropriate follow-up appointments, and receive alerts and other information, such as information regarding health promotion and education." Unquote. An important hallmark in the evolution of population health technology is how the data sets used by various vendors is broadening. During the initial years of value-based payment models, the conversation encompassed primarily EHR patient care data and claims data sets and the ability to combine the two. We have evolved beyond these essential data sets to include broader sources of data, and with each source of data come a set of issues such as reliability, accuracy, data normalization or standardization, patient matching, and so on. When we acquire a population health management solution, these are some of the capabilities you are paying for. Addressing and solving these issues is a big part of the value add provided by population health management vendor solutions. Even if it is not your role to acquire the technology, it's helpful to know what it does so you can understand the possibilities of gathering additional data to conduct analytics to answer unknowns about the patients your value-based care model is responsible for. Although population health management is evolving and becoming more widespread, many healthcare organizations are in the beginning stages, using the HIT tools that they have. Remember the mantra, start where you are, use what you have, do what you can. As a first step, population health analytics starts with claims and electronic healthcare records data being used to perform risk analysis and identify patients who need follow-up care. As we progress, there will be new data to collect which will provide the population health management analytic engines and algorithms to provide even greater insights into value-based care populations. There are also publicly available data sets that you can access to learn about patients in your geographic area and help to further identify risk, health disparities, and other information beyond the data that you may currently have. Understanding where disparities occur and what is driving those is a critical first step in working to promote health equity. In the upper right corner of the slide, the U.S. map from the Rural Health Information Hub shows poverty by county and allows you to drill down to that level of detail. There are many data sources like this that provide access and insights to data when looking at a population from different dimensions, geographically, by race and ethnicity, income, employment, and many other factors that are social determinants of health. You'll have to explore the websites and have a conversation with the data owner to see if the data can be collected and utilized by your own population health management tool, or if it can only be viewed and queried via a web page application as we see here on the slide. Just as greater insights can be gained by combining clinical and claims data, the combination of more data sets with those core 2 data sets provides a better picture of your population and ability to answer specific questions you may have about your patients. For example, the graphics and map in the lower portion of this slide come from New York State's Department of Health Vital Statistics and focuses on years of life lost when comparing the African American to white non-Latino population, with the circular diagram going into the detail of what categories make up the reasons for the reduced longevity of this population. The next step after collecting the data is to use a population health management application to analyze and stratify the data, and we'll look into these steps next. Analytics is a process that incorporates data collection, extraction, transformation, analysis, interpreting, and reporting. The analysis in analytics is just one of many steps. The definition on this slide comes from the National Institute of Standards and Technology. They define analytics as, quote, the discovery of meaningful patterns in data, and is one of the steps in the data lifecycle of collection of raw data, preparation of the information, analysis of patterns to synthesize knowledge, and action to produce value, unquote. The diagram shows the 4 major types of analytics that can be done on data sets with an increasing level of value as we move up and to the right. Starting in the lower left, we see the basic or rudimentary level of analytics, descriptive analytics, which can tell us what has historically happened with our population, or hindsight. This is typically what happens when we receive reports on data long after care has been provided, whether weeks, months, or even a year. Moving to the next level, we get into the exploratory phase of why things happened, known as diagnostic analytics, where we start to gain insights into our population. It really starts to get interesting where the sophisticated tools in population health analytics can start doing predictive analytics, or what will happen. This is where and how we start to get ahead of a patient's health and work with them to intervene before emergent events happen. This level of analytics brings part of the value to value-based care models. Lastly, with enough data and sophisticated analytics, we can advance to prescriptive analytics, where we can make things happen. This highest level is where we know enough about the population and the individual to discuss and recommend or prescribe specific interventions, similar to the way precision medicine helps us target one patient at a time, rather than recommending an intervention that is generic for an entire population with a certain diagnosis, but may not be effective for certain individuals in that population. Don't worry if these terms are entirely foreign to you. The takeaway is that population health analytic tools use some very sophisticated methods to extract the meaning from the data, identify otherwise undetectable correlations, and present the users with deeper insights. You might also notice on the diagram that the type of analytics done in the lower left portion, descriptive and diagnostic analytics, are the type done in a typical fee-for-service environment. As we move up and to the right, predictive and prescriptive analytics are where we need to move to as we transition to value-based care. An important next step in the process we apply to our populations and data sets is to risk stratify the patient population into groups according to health categories and care needs. Risk stratification is essentially grouping individuals according to health concern categories and increasing levels of care needs. The goal of a population health management program is to keep these patients healthy and in the low risk category. The base of the pyramid here is shown with 50% as latent or lower risk. In the middle tier are the increasing or sometimes called rising risk groups, 45% in this example, who we need to reach out and work with so that they can have appropriate care to prevent, as best possible, emergent or development of acute problems. The top tier represents individuals within a group with the most acute concerns. The top tier includes individuals at high risk for certain outcomes with multiple comorbidities. This 5% of patients can account for up to 50% of healthcare costs as they have high acuity conditions. Those working in value-based care models need to have the ability to identify the top health risk concerns across the populations they serve, such as diabetes, cardiovascular diseases, and/or chronic obstructive pulmonary disease. We often know the concerns and top diagnosis of the 5% or 45% groups, but running analytics frequently unearths insights into our broader population and can help us to reformulate who we reach out to inform our long-term care strategies and programs, and help us apply resources within our system in a more targeted and data-informed approach. In other words, create more value for our patients with the limited resources we have. Grouping patients based on age, condition, risk, etc., data segmentation, allows providers and care teams to develop appropriate evidence-based interventions targeted for each group. The capabilities built into population health management applications are essential, as a value-based care contract includes identifying and managing risk within an attributed population. Risk stratification helps to put a lens on which patients may need additional services and support. An example from the Vermont OneCare Accountable Care Organization is the use of 4 tiered categories using a population health management predictive modeling approach to risk stratify their beneficiary population into 4 categories. The ACO calculates a risk score by using administrative claims data related to healthcare utilization, information on diagnoses, and pharmacy codes. Based on the risk score, OneCare places individuals into one of the following 4 categories: low risk for healthy beneficiaries with limited or unavoidable utilization, medium risk for beneficiaries with early onset or stable chronic illness, high risk for beneficiaries with full onset chronic illness and rising risk, and very high risk for beneficiaries with high cost, high acuity conditions. Items 3 and 4 corresponding to the top 5% category in the pyramid. Notice that the risk stratification diagrams from Vermont OneCare approximates the 3-tiered pyramid. As you utilize a population health management analytics tool and gain detailed insights into your population, you'll see a breakdown that approximates these categories of risks. But more importantly, these categories can be broken down into specific patients within the groupings and translated into the interventions, provider assignments, etc., that are needed to address and work with patients. The goal is to help them lower their risk and move into lower risk tiers. As a key performance indicator, an accountable care organization could look at the percentages of their attributed population that fall into the various risk categories and measure the downward shift of the percentage moving to lower risk categories over some time period. Each vendor will utilize algorithms, which are mathematical and statistical models that identify and assign risk scores or factors. Johns Hopkins Adjusted Clinical Group (ACG) system is a widely recognized and utilized algorithm and model relied upon by many population health management and EHR vendors. Vendors will also develop and highlight their own proprietary algorithms. For example, Lightbeam Health Solutions has developed their own unique Ability to Impact (ATI) proprietary algorithm that identifies patients whose resource utilization is most likely to decrease through active care management. Some of the more common algorithms are listed on the slide. Whether you are working with the application directly and utilizing an algorithm or the recipient of its outputs, it's important to understand how and why the application produced the results and not treat it like a black box that magically produces correct results. Another result of the analysis done on your population level data can be used to identify gaps or opportunities such as those on this slide. These include gaps in diagnosis such as misdiagnosis and miscommunication, gaps in treatment like quality gaps or documentation gaps and payment gaps, as well as undocumented risk factors and coding misses. In an article by Health Catalyst, a healthcare data and analytics company, they state that, quote, accountable care organizations need to be able to prioritize opportunities based on identifying individuals at high risk of certain outcomes or conditions in high volume areas of inappropriate variation that significantly drive cost in order to appropriately and effectively focus their resources. They also need to develop meaningful metrics for individual patient conditions, especially for chronic diseases, and for population health and well-being. This requires a highly sophisticated and flexible analytics system, unquote. The third of the 3 major steps in working with population-level data in a population health management system is to utilize the knowledge and insight gained from the prior steps of collecting and analyzing the data. Once analysis and stratification has been done, the outputs need to be translated into action for individual patient-level care. Session 3 will help us to narrow our focus to specific population and patient care using examples around care management, care coordination, and the technologies that utilize the knowledge and information gained when first working at the population level. A nurse that utilizes one of the population health management suites of products summarized her experience this way, quote, Much of the data that we had in the past from the EHR was information required for reporting rather than what we needed for change management or real process improvement. It didn't give us insight about how to improve care across our populations. Now we have access to the kind of information that we need to drive our plans for improving our workflow and managing our populations." Unquote. The kind of information the nurse was referring to are the broad population insights that she and her team did not have before using analytics as part of a population health management application. Population health management tools need to provide outputs that yield insights into and understanding of quality metrics, translation of risk stratified lists of patients into provider level dashboards, the ability to drill down into patient level detail, and with more advanced systems, data should be moving you closer to real time to enable actions and improvements such as outreach and interventions to patients at high risk. As we come to the end of session 2, let's step back and think about technology as one of the components to successfully implementing value-based care and shifting from reactive to proactive care. Technologies enable the shift to become proactive and help us to stop driving in the rearview mirror. Think back to the slide showing the different types of analytics and how we move from hindsight to foresight. Using this analogy, descriptive and diagnostic analytics are the rearview mirror approach, where it is too late to undertake interventions with patients to make a difference in outcomes. Using foresight, predictive and prescriptive analytics is like driving looking forward or as far down the road as possible and anticipating care needs and being able to intervene before our patients' health needs become emergent or acute. The Office of the National Coordinator for Health IT put together the HIT Playbook for Value-Based Care, which is linked in the resource slides at the end of this presentation, and included these 6 ingredients of success, shown on the slide here, from facilities adopting value-based care. This last point, data access and analysis, underscores the need for technologies that can produce the level of insights and how we manage and support the health of populations. And the 5th point, care coordination services, will be covered with a lens of how technology supports value-based care in the next session. Population health analytics also offers an important opportunity to advance health equity. When we are analyzing very broad sets of patient population data and trying to gain information required to translate insights into action and interventions, we need to look for and understand what the outputs are telling us about potential disparities. Are there any biases built into the algorithms? For example, is most of our data representative or biased towards Caucasians, gender biased, or certain age groups? Do we have sufficient data collection to capture accurate race, ethnicity, and language (REL) data that can help tell us more about individuals and where the equity gaps may exist from these dimensions of our community? Do we have social determinants of health data incorporated, whether acquired from individual patient screening or questionnaires, or from publicly provided data sets that can help provide, for example, indications about the environmental risks that our patients are exposed to in their daily lives? Working with population health management analytics and algorithms is a perfect opportunity for us to ask ourselves how our system, how our processes are being built, and whether there's any conscious or unconscious bias built into the processes and systems we are putting in place. We may need to have deeper conversations with vendors about the algorithms that are describing and providing insights into our populations, as these black boxes, while amazing in the power to create insights, may have their own inherent biases. Biases in our data and algorithms can lead to medical treatment and care decisions that disadvantage certain groups, such as communities of color, if these decisions are based on data that do not accurately represent their risks and care needs. The National Association of Accountable Care Organizations provides examples as ways to utilize technologies to address health equity gaps, leveraging information technology and analytics for targeted outreach to identify patients with unmet needs, identifying discrepancies in patient populations and providing additional interventions to address identified gaps, focusing on end-stage renal disease and chronic kidney disease, which disproportionately affect Black patients, to shift care to better, less expensive settings that meet patient needs and preferences. Developing tools to identify and reach out to high-risk patients with trained staff to check for food and housing insecurity and verify that they have access to needed medications, which touches on social determinants of health data insights, which we'll cover in session 3. A link is provided in the reference section to the role of ACOs in addressing health equity that goes into more details and recommendations on how value-based care can improve health equity and reduce disparities. In this session, we have reviewed population health management with a focus on 3 major steps of data collection, analysis, and stratification, and then utilizing what we learn about a population to accomplish value-based care goals. We also learned about the typical risk percentages that populations are segmented into, with the top 5% being a primary focus for value-based care. Finally, we took a brief look at health equity in the context of value-based care, and we'll return to this topic in sessions 3 and 4. Next, session 3 will take a closer look at managing and supporting patients using technologies such as care management and care coordination tools, health information exchange, telehealth, and others. The content of this session is based on many articles and web-based resources, and those are available in the following slides along with resources that have not been mentioned but you may find useful. A separate PDF document is available with the slides for this session, including the reference and resource slides that follow. The following slides that you'll see briefly have active hyperlinks in the PDF document to make the references and resources easy to access. Thank you for taking time to review this second of 4 sessions.